So it is now my privilege to introduce Dr. Kristen Carpenter over here to my right. She is a clinical health psychologist and associate professor in the Department of Psychiatry and Behavioral Health, Psychology, and OB for, the Ohio State University as well. That's fine. She doesn't play football. She's okay with it. As well as a member at the OSU Comprehensive Care Center. She's a chief psychologist and director of ambulatory services in the Department of Psychiatry and Behavioral Health. She leads the OSU Women's Behavioral Health Program. In this capacity, she provides clinical care to women with sexual dysfunction, education to staff throughout the OSU Wexner Medical Center and James Center, training to psychology doctoral trainees as well. She also serves on the steering committee of the Scientific Network on Female Sexual Health and Cancer. Dr. Carpenter's research involves understanding the role of cognitive, affective, and interpersonal processes in women's sexual, psychological, and physical health outcomes. Let's welcome Dr. Carpenter.
Appreciate it. I don't have anything to disclose other than the vast majority of what I do, as all of my titles would imply, is with women. So that's where I'm going to focus most of my energy today. I got into this as soon as I started graduate school. So in 2000, I sort of came on board at Ohio State with Barb Anderson. Some of you may know Barb. And she said, you know, Kristen, sexuality is interesting and everything else, but what do you think about doing your master's, so your first project with us, in cancer patients? I was like, yeah, sure. I'll do anything once. And so, 22 years later, it's tough to walk away once you sort of get the bug, I think. I've interviewed hundreds of women at this point, asking them about their sexual experiences in the context of cancer. And they all stick with me, but one in particular, in one of our intervention trials, I asked all the women routinely, why did you decide to do this? And lots said, I want to help others, I'd like to see if this works, I want to help science. But one woman in particular said, well, Kristen, when I was diagnosed with ovarian cancer, I was sure I was going to die. But now I know I'm going to live. And if I'm going to live, I want to live fully. And I think that that's the important piece that we need to think about. So here are our objectives for today. And in the patients that you're caring for, bear in mind that there are big pieces to their full lives, even as they're diagnosed quite young. And cancer impacts sexual function for most, not the majority. But there are common sort of misconceptions that I think contribute to and maintain patients' difficulties, men and women alike. That difficulties occur in only a smallest percentage of patients, that they will go away with time, that other psychosocial concerns like anxiety, stress, the acuteness of diagnosis need to resolve, and then the sexual stuff will resolve as well, and that somehow sexuality is routinely addressed within the team. But what we know now from many, many studies, observational and otherwise, is that these difficulties are common. Studies tend to be with survivors, so they are persistent. They tend to contribute to poorer quality of life and psychological health outcomes rather than the converse, and it is often not addressed by the team. And so what is getting in the way? Now, patients will tell you in large numbers, if you sort of take many of the studies that have been done, that they want to talk to their providers about their sexual lives. Providers will tell you in even larger numbers that they think it's important, but patients don't ask, and providers don't bring it up. When you ask patients, and these are sort of a hodgepodge of studies that have been done with cancer patients and not, they are concerned that their provider will be unresponsive or unhelpful, that they might dismiss those concerns, that their provider will be embarrassed. Providers don't bring it up. They just say they don't talk about sexual issues, maybe rarely, occasionally, only if the patient brings it up, sometimes only if the patient is young. And I bring this up, this is not new. So this, as you can see down at the bottom, this is a study that was done, published in 1975. This is science that is almost as old as I am, where people are saying essentially the same thing. We see high rates of sexual difficulty among those who were treated, who are saying that I am having sex, I have less interest in sex than I did before my illness or treatment, or I'm too sick to engage in sexual activity. And even then, patients expected their physician to initiate this conversation with them, with 79% of the 28 wanting more from their providers. And so you can see sort of the questions that people are asking. Some of the questions are different now. Maybe not. I don't know if as many women anymore ask about radiotherapy affecting their husband's penis. They may. It's not as common a complaint that I hear anymore, but I'm sure the radiation oncologists might hear. But these barriers remain to meeting our patients' sexual health needs. And when you ask when you see these surveys of physicians, of providers, of NPs who care for patients, what they say is that they are embarrassed or lack experience with this information, and that's part of why they don't bring it up, that they lack the knowledge or expertise to be helpful, or they lack the time or resources to do anything for that individual. Luckily, most of these are surmountable with some effort. You can practice to overcome lack of experience and embarrassment. You can seek out education. And I think the most important thing when we think about all of the work that needs to be done in a consultation is setting realistic goals for how you interact with your patients. So I'll give you a little bit of information today that you can hopefully take with you. Now, hopefully you are familiar with Masterton Johnson's model of sexual response. Hopefully you've heard of Helen Singer Kaplan and the work that she did around desire in the 70s. But the way we think about sexual response now is a little more complicated than just the physiologic stages of response. So we're thinking more about motivation, about attention to stimuli, and about all of the variables that might influence individuals' desire, arousal, sexual satisfaction, the presence or absence of pain, and orgasm. But we still think about those basic kind of Masters and Johnson-esque constructs when we're thinking about sexual dysfunction in the diagnosable sense. So for women now in our sort of most recent iteration of the DSM, we have female sexual interest arousal disorder, orgasmic disorder, and genitopelvic pain and penetration disorder, which is a subsumed vaginismus and dyspareunia. In the DSM-5, we see for males, a male hypoactive sexual desire disorder, which is a carryover, erectile dysfunction, premature ejaculation, and delayed ejaculation. So really focusing on physiologic response. Now you'll see a lot of things in magazines, in interviews, that like sexual problems among women are rampant. Part of the reason is that when you ask people how things are going in survey, they'll tell you that they are having some kind of problem, but the prevalence is highly, highly variable. So would you like to be more interested in sex? Yeah, like lots of people will say, yeah, I would love to be more interested in sex, but I'm tired. I have things going on. There's more in my life than just this relationship. But when we think about what we're diagnosing in the clinic, some of that is very normative. And so these prevalence numbers that you see aren't super useful until you think about whether or not those issues with sexuality are associated with distress. So if there is some kind of interpersonal distress for the individual, then that is something that is of clinical concern. So that's kind of, these are not cancer samples. This is what you see in sort of normal, healthy samples of women. And so the point prevalence is about 15% at its height in the 5th decade of life, in the 50s. And then it sort of goes down as women get older. But when we think about sexual morbidity in the context of cancer, we can't just be thinking about dysfunction. You have to think about all the ways in which sexual lives can change. So we see changes in behavior, so reduction in sexual behavior, like restriction of repertoire is what we would call it, so less varied sexual behaviors and activities. There are, of course, the functional bits. Can you get sufficient arousal? Can you actually feel and become aroused? Are you interested in sex? Do you have spontaneous sexual arousal that leads to desire? There's the emotional and affective piece. Are you distressed about your sex life? Do you have guilt that you can't perform in the way that you wish or that you're not interested? And to what degree are people physically satisfied with their sexual activities? So these things have to occur then within a context. It's an interpersonal context, it's an intrapersonal context, and it occurs in sort of it occurs differently, and all these variables weigh in differently in different stages of life. And in the context of many of those that you're caring for, adolescence is expanding. So at the turn of the last century, periods started much later, of course. Marriage occurred much earlier. Now we're seeing, most recently in 2019, I'll show you in a moment, even further out, we're seeing a much longer interval in what we think about as adolescence and young adulthood. And so we have this sort of notion of the emerging adult. So not just adolescent and then adult, but the emerging adult. And as you look at sort of even census data from the United States, we continue to see age of first marriage, which is a nice marker sort of how people are coupling. Whether people couple differently or not is sort of irrelevant in some ways, because marriage is a good indicator of when people are choosing to make a commitment to another individual. And so it keeps going up. Even as recently as 2019, all we see is increases. And what you also see with these data from the census is that individuals who are married tend to have more socioeconomic resources and others. So paying attention to these markers gives us a good indication of sort of who might be suffering and for how long. We also have to think about at what proportion our patients are having intercourse. Many of the people that you are caring for either have had sex, are having sex, or will very soon. And keeping that in mind as you have your conversations with patients, I do think is important. It might not be the right time to intervene on sexual difficulties when you're with them, but I do think it's important to keep in mind that they are sexual beings. And that trend will continue then, for most, throughout their adult lives. And you see that the vast majority of individuals, at least in the United States, are sexually active throughout most of their adult life, even into much older age, when you consider things like partnered intercourse, but also masturbation for both men and women. We've also seen, which is sort of heartening in some ways, a kind of convergence of age of first sex and age of first contraceptive use. So really, we are seeing that most people are using contraception in the same time frame as they're having their first intercourse. However, our young adults are not super, as you could expect, not super consistent with that idea. So more than 46% of sexually active high schoolers will tell you they did not use a condom, for instance, the last time they had sex. So even though we see higher uptake of use, it is inconsistent, and an important thing to sort of keep in mind and reinforce for patients as you're interacting with them. So in thinking about sexual morbidity in the context of cancer, that's all the developmental piece, but cancer brings a whole new set of challenges and changes for all of our patients. It is not just about the breast. It is not just about the uterus for our breast and GYN patients. It's not just about genital organs for any of our patients. They experience a variety of changes that influence the way they think about themselves as a sexual being and the way that they are able to move in the world. This sort of sense that their body has failed them, that they are prematurely aged. Some have apparatus that they have to continue to contend with, and even little micro changes, the way their hair looks, the way their nails feel, the way their skin feels, all remind them as they go through life as a cancer survivor. And so the most common concerns that we see across diagnostic categories are things like body image concern, feelings of unattractiveness. We see lots of changes to the relationship dynamic when there is a partner involved, someone who might have had to take on a caregiver role that hadn't had to do that previously, and so negotiating that kind of differential becomes a challenge for some couples. Some partners have fears or worries that they could actually harm the partner if they continue to engage in sexual activity. Patients will often experience long-term fatigue, malaise, loss of stamina, whether it's a chemotherapy agent or radiation that is a little bit less long-standing, or if they're taking the kinds of immune therapies that we now see them taking. Patients have subjective complaints of these things that influence their ability to interact in a sexual way with themselves or with another person. Also concerns about compromised immunity, and with any of our patients, there tends to be, if there was an intimate routine, a significant interruption, right? So if you're diagnosed at 25 with stage 2 breast cancer, you're going to go through surgery, you're going to have chemotherapy that's going to be long-lasting. If it's a hormone receptor positive tumor, they're going to put you on an endocrine therapy for a period of time. And very often, much of that period will be without any sort of touch, without any sort of sexual contact. And so as time drags on, it becomes harder and harder for even established couples to kind of figure out what to do, let alone people who are trying to enter the world of dating or finding a partner under those circumstances. And of course, in a subset of our patients, there will be hormonal changes as a result of their treatments, which will impact their ability to enjoy sex and all of the things that you do. In our AYA patients, there aren't as many studies, but it is clear that cancer negatively impact sexual functions in adolescents and young adults. So this is just some data from the HOPE study. What we see very clearly is 1 year after diagnosis and then 2 years later, or 2 years after diagnosis, patients are continuing. It's a little bit better after a year, right? But you still have 43% 2 years after diagnosis reporting that they have had a very or somewhat negative impact on their sexual function and intimate relationships, and continue to have significant concerns. Half of them continuing to have significant concerns about their physical appearance. We also know that poor sexual function is associated with being diagnosed from 25 to 39 in this sample, with fatigue, with childlessness, and with body image disruption. Here are some data from Sharon Bober. Consistently poor. Again, she looked at kind of the subsets of sexual problems with delayed sexual milestones in this sample of, I think, 291 with an average age of 27 years. They had fewer lifetime partners, less likely to marry, less frequent sexual activity, and a half reporting some subjective impact on their sexual lives, kind of in these categories here. And this was a mixed sample of males and females. And what we see kind of over and over again in these samples of AYA individuals is that non-mutable things contribute to poorer outcomes. So the age they were diagnosed, did they have a brain tumor, what kinds of treatments did they receive? So we sought to figure out what we could change. You know, are there targets we could actually look at here? So we just finished up just as the pandemic hit, but we have 136 dyads, you know, matched pairs of individuals, 18 to 39. We first accrued our cancer sample of survivors and then matched them on partner status and age with healthy controls. And what we found is consistent with what you see in survivor-only samples, that we have poorer sexual function and sexual outcomes in our survivors. But what's interesting is that they also experience more negative emotion and cognition related to sexuality. And those are things we can change. That's a thing I can work with. And so it gives us a little bit more insight into how we might intervene with these folks. They tended to have higher distress associated with their sexuality. They tend to be more embarrassed and conservative in sort of their sexual views of themselves, and lower sexual self-efficacy, or their sort of thoughts about themselves as being capable in a sexual interaction. And those are definitely interventions that we can help. And so what do we do for our patients? We at Ohio State, I think, have done a pretty nice job over the past 10 or so years to make sure that patients have access to something with us. So every quarter, we do an education session for women who've been diagnosed with any cancer at any time. They can come, one of us gives kind of a brief overview. It's modally about 5 to 10 people, and so there's often a lot of opportunity for interaction, which we can then give them information about the services that we offer clinically. We also have made it very easy for folks in our oncology community to refer to us in our Women's Intimacy and Sexual Health program. We do individual consultation, we do education, and we do a full-blown psychological intervention when it's necessary. We partner very closely with our pelvic floor physical therapy teams for both men and women presenting with sexual problems. They are a wonderful resource. If you do not have access to good pelvic floor PT, I suggest trying to find someone in your community. We also have a very committed NP and OBGYN in our sexual health clinic if we think they need some kind of medical intervention or surgical intervention. So we have been able to sort of build a service. Ours includes myself, one other psychologist, and two master's level psychotherapists that work with sexual difficulties, and then 2 couples therapists. And so we're able to do much for our patients in these ways. As far as what do we do when we get them through the door, there are actually a number of really nicely done trials of sexuality interventions. How am I doing? Like 4 more minutes, okay, good. So, I mean, the good news is, like, when we do these things, they help. They make a difference in people's lives. And some of our own work has also made a difference. So this is a small RCT of GYN survivors. We had an active control where they got sexuality education and progressive muscle relaxation, and sort of a full-blown sexuality intervention that we did in a group format. And we saw very nice improvements across a variety of domains. This is just their total female sexual function index score, their sexual satisfaction, and we had significant improvements actually in pain, which is great for this population. It's a hard marker to touch. And at baseline, 78% of these people, these women, were scoring within the clinical range for sexual dysfunction on that FSFI. So this is a highly dysfunctional population whom we were able to provide assistance. We did the same thing in a single-arm pilot in a breast sample, just to see if we had to actually modify the intervention for a breast sample. I would like to be able to give it to mixed groups. And what we found was very nice pre-post outcomes, and then again following up out to 9 months with fairly reliable change, and in this sample more moderate effects rather than the large effects that we saw in the GYN sample. But these things work at the end of the day, which is incredibly heartening for those of us who do this. So where we go from here, we have efficacious interventions for sexual health issues in cancer survivors. We just do. But it is still an important unsolved problem because we're not like drawing that line between what we have and what we can offer to reach as many people as we can. And so I think the most important questions are, how do we get the right interventions to the right patients when they need it? And perhaps also when they want it. Because not everyone wants every sort of intervention 2 weeks after they got diagnosed. Sometimes these things come to us later. And then what's the right context in which to deliver it? We deliver it through our clinics in psychiatry and behavioral health. That is not the only way to do this, but it has worked really well in our setting for a variety of reasons. And then importantly, who pays for it? Most, if not all, of what we do is reimbursable by insurance. And so we choose to bill for our services. I choose to give it away, much to the chagrin of my boss, when someone is not in network for us, or when she can't make it down to get coverage, but that is within my purview as a chief and a lady in charge of things, and so I go ahead and give it away when I can. But I do think that the most important thing that we need to do, those of us who are doing sexual health work, is not just to do bigger trials, right? We need to do better trials. We need to do trials that have an eye to dissemination and helping figure out how we kind of cross that bridge, how we fill in the dots in that line, as it were. And I will say telehealth has made a big difference. We are a tertiary referral center, as I'm sure many of you work in, and so I can see a woman from Ohio from 3 hours away just as easily as I can see the one who lives right down the street now, which is fantastic. And that is going to be true across most states in the United States. With telehealth, given that they've waived kind of all the restrictions that previously existed, what we need to work on, though, is the ability to cross state lines. And there's some things for psychologists that will allow us to do that. But I think just as there's a huge problem in Canada with access, we have many women who do not have the opportunity, and men who do not have the opportunity to reach someone who can be of assistance to them. I will give a plug for the Scientific Network on Female Sexual Health and Cancer. It is a group not unlike this one of people who do this very specific thing. We'll be meeting at Yale this year in the fall. I'm sure it'll be lovely. I don't know when leaves change there. Perhaps some of you do, but hopefully it's around that time. And that's November 17th to 18th. If anyone is interested, I think that these slides will be made available and would like to read more on what kinds of specific suggestions or things you could work with on your patients. There's a very nice paper that many of us put out a few years ago in Current Opinions in Supportive and Palliative Care. And that's it. I'm happy to take a question.
Fan. She needs a fan.
I'm sorry, I'm having a hot flash.
You know, being a woman.
I've also done this when pregnant, and so I've really experienced a lot of the things a woman's body can do right here on stage.
Kristen, you are so brilliant. I always love listening to you talk. I do want to open this up to some questions if anybody has any for her. I don't have a question, but just a comment. You know, we keep thinking about, are we asking this question about sexual health? Are we bringing it up? Are doctors bringing it up? Are nurses? Who's talking about it? And I found it just so enlightening that, you know, I'm working in a pediatric and adolescent young adult population in gynecology, but we also have a presence in our Cancer and Blood Disease Institute clinic. And I always appreciate the fact that my pediatric adolescent gynecologist will ask every patient, whether they're about to start their first dose of chemo, are you sexually active? And if they say no, we will still ask, do you see that happening in the near future.
Yes.
Because it's not a hard stop no, and we have to keep that question going, because you will get the response of, well, I just met someone. Can I? I actually can now with treatment, and maybe, but I would have just already shut that down with your first question. So bring it along. Go to that second one, and you'll be surprised what you learn from your patients.
An adolescent is very good at answering the question they were asked and
Amen.
not elaborating, right? Yes.
Yes, thank you for this excellent talk. I'm Astrid Eil from Switzerland. I'm a reproductive endocrinologist and sexologist. And so I think first is a comment, because comment is, I think everybody here is so concerned about preserving fertility, and that's great. And then you tick the box, and then it's saying, okay, great, we did a great job. But then we completely forget that we have only 10% or even less coming back and using their tissue or the gametes. And so my point is, I think, before you can even think as a survivor of having a child or a family, before that, you have to find a partner potentially. And before that, you should first of all feel good in your body, and then perhaps also work on your sexuality, because we know that they're struggling with building up intimate relationships, and all the rest of it. So I think we should really more focus on how we can enable our patients to really find a partner, and then even give them the opportunity to think of having a baby in the future. And then it was fantastic when we did freeze gametes before that.
Marvelous, yeah.
You know what I mean? So anyway, but great job. And then the second thing is just that you're talking, I think there are some amazing stuff out there when you have a dysfunction. But I think it is also important to be there before that, right? So I think we can do, I think it's important, especially in the adolescents, to help them, and that they can answer questions. And so what I found is to address the topic of sexuality is even more difficult in the oncology setting than the fertility preservation topic,
I think so. I think that's probably very true. And we are very deliberate in our clinics about reaching anyone at the point of care, whether it's the PAs that work with the physicians, the NPs, our RNs. We go out and do as much education as we can, and we try to make as much available to patients as we can. We have pretty well done patient education materials. It's all part of their chemotherapy binder, which is this big. But we do try to make sure that wherever there's an opportunity to bring this up, it is, so that even if it's missed in that conversation, and very often it is mentioned in the room, but it's a matter of also what patient hears and what patient processes. And it is funny, we're all taught, at least I went to Catholic school, I got taught real early that if you have sex, babies come. Right? But when you look at the literature around effortful conception and sexuality, they are often quite divorced. When people are actually trying to have babies, sex becomes another thing. And I think that carries through into this context as well. It is an easier room, perhaps, to ask questions about sexuality since you are talking about babies, but I do think it's important to think of these patients as whole people who have a whole life ahead of them, and who deserve to live fully.